So it is now my pleasure to move on to the main event and introduce today's speakers. Janis Geary, PhD, is a science policy and health researcher with degrees in microbiology and public health. Janis's science policy research has focused on governance, shared resources, including data, and she has spent over a decade working in partnership with First Nations and Inuvialuit in Northern Canada to address community health concerns. She has examined data sharing practices and preferences within a large international research collaboration and has reviewed data management strategies from funding agencies, academic institutions, community organizations, and other nonprofit organizations to learn more about how data management approaches can both support and hinder the research and policy goals of diverse groups. And Naomi Hamm is a PhD candidate in the Department of Community Health Sciences at the University of Manitoba. Her research focuses on using longitudinal administrative health data to improve methods for chronic disease surveillance. She is currently funded by the Visual and Automated Data Analytics Training Program. I'll turn things over to our first speaker now.
Well, thanks so much for the introduction, Emma, and I'm so excited to be chatting with you all and sharing some of my thoughts around data sharing and open data and all of those things. So I'm just gonna there we are. So I'm just going to start off by giving a broad overview about open data and data management in general. So just drawing from the Government of Canada's definition, open data is defined as structured data that is machine readable, freely shared, used and built on without restrictions. And actually all of the components of that definition are really important. Structured data means that variables have defined relationships. Machine readable means that you can use programs to go in and pull the data out. It's freely shared, meaning you can download it off the internet and that you can use it and add to it without restrictions on that. And that's what we think of when we talk about open data. Now, open doesn't just mean that you're allowed to use it. For example, if you think about someone's lab books that are sitting around, if you were to approach a researcher and say, you know, I'd like to use your data, and they're okay with you coming in and taking their lab books and their information, that's something that they're willing to share, but it doesn't make the data open because lab books aren't structured, they're not machine readable. Just because they're available to be freely shared doesn't mean they're actually accessible, and it's really difficult to build onto that and use it. So it's just not accessible data. So that's why open data has this very specific definition. There's lots of examples of open data. I've shared a link to look at the City of Edmonton open databases. They're very well known internationally for providing open data about government, and that's where you see a lot of discussions around open data is within the government context. And of course, this language transfers over to research, as a lot of research is government funded as well. So you see a big push for open data and data sharing within the research branch as well. CIHR has its own open data approach, and just so you know, you're getting these slides and all the links are active, and you can access these resources as well. So you can go and learn about CIHR's, the Canadian Institutes of Health Research, their open data approach. And of course, open data is also pushed by the people who publish our research. So journals and funding agencies alike both want to encourage data sharing. The funding agencies have a motivation based on wanting to make data that they're producing through their funding accessible to the public, and publications have a slightly different approach, whereas they want to share the data that supports the work that's being published within their publications. Of course, there are lots of options out there for how you can actually share your data and make it open and available. A really well-known one is Harvard Dataverse. You can use the actual program that's installed at Harvard, but the Harvard Dataverse software has been installed in over 3,000 institutions globally. They provide this service to other institutions, so they can have their own locally housed servers with their data stored locally, as opposed to being in other countries, to get around some of those challenges as well. And there's general data repositories like the Harvard Dataverse that I mentioned. Any type of data can go in there. There's discipline-specific repositories. Institutions might have their own repositories, and you can go to your institutions to find out if they support database development and repositories at their institution. Journals will also offer the ability to store the data with the publication within the journal itself. So you can have data stored within a regular journal. So you might publish through the Public Library of Science through PLOS, and onto that normal publication you can attach a data set, or you can actually just publish data sets. So the journal Scientific Data is a journal where you can just actually publish your data as well. So moving on to what data management is, when we think about data management for research, so I'm just looking at the time here to make sure I don't go over. Data management kind of dictates the whole process from thinking about how you're going to collect data, what you're documenting, how it's formatted, protected, and preserved, how existing data sets could be used during the research, what new data you're going to create to go along with that over the course of the entire research project, and whether and how data will be shared, along with where the data will be deposited. And along this line with data management, you might have come across, and it's very common to come across, the FAIR guiding principles. So the FAIR guiding principles of data sharing are that data should be findable, accessible, interoperable, and reusable. And you can learn more about what those terms mean as well. But that's the main principle that a lot of people talk about data sharing, and what data management should be aiming to accomplish when you think about the whole process of it. But one thing that I really like to emphasize is that not all data can or should be shared. So open data is often assumed to be the goal of data management, and the two concepts are related and they show up together quite a lot, but they're not the same thing, and it's a bit problematic to conflate them. So just because something is openly accessible, it doesn't mean there has to be unrestricted use on what happens with that when it's accessible. And this is a bit complicated because when you think about open data, as you heard in the definition, people always think about open data as unrestricted use. But the idea that something can be openly accessible but still restricted in how it's used is something that we come across all the time. Copyright is a great example of this. Just because a paper is openly accessible to read doesn't mean you can copy and paste that, the writing in that paper, and use it however you want. There's restrictions on how you use it. So that's one thing to think about. Open data is its own specific thing that is free to use for any reason, but not all data management has the goal of producing open data. So another example of this when you're working in government is that a lot of government aims to have open data that's available, the Government of Canada, Edmonton, like I provided. But for example, in Alberta, the government has access to data with Indigenous identifiers and data that's coming from Indigenous communities, but the government actually will not use or share that data without the permission of the Indigenous groups that the data pertains to. So as a health researcher, you can't get data from Alberta Health Services about First Nations in Alberta without going through the Alberta First Nations Information Governance Center, because they have control over that data. And you couldn't share data that has to do with Indigenous communities without going through them as well. So you can actually, when you're sharing data, you don't have to just have it all or nothing. You can create end use agreements where the data is only used in specific instances, or you only allow certain types of end users to use data. What's really common, as you've probably seen, is non-commercial use. It's pretty common to see data that's shared only for research or academic purposes. I want to talk a little bit about the motivation and challenges around data sharing and management as well. So basically, the main motivations for why people push for data management and sharing is that often data is produced through a public investment, and public money should be used to create things that benefit the public, and there should be accountability. We want to use resources efficiently and reduce duplication. It also enables verification of findings, so you can actually download a data set from a publication and ensure that when you use the same data, you can draw the same conclusions. But there's problems with data sharing. Importantly, it's actually just really difficult to get people to do it. It's a collective action challenge where we try to get people to do something that benefits the group, but doesn't necessarily have a benefit for them immediately. And one thing, as a person who studies the governance of shared resources, that is a pet peeve of mine, is that the language that something is a public good comes from the literature around shared resources A public good is a very specific type of shared resource where it's hard to exclude people and it's non-subtractable. And that means if you use it, doesn't mean that I can't use it as well. This is often conflated with something being good for the public, like making something a public good by making it really easily accessible that anyone can use means that it's inherently good for the public. And that's not the case, and I'll talk about that a little bit more. And often when we think about data sharing, it's coming from a very specific mind frame of that data sharing is inherently the right way to approach things. And these guidelines have been produced with, a lot of scientific guidelines in particular have been produced with that idea in mind. But who produces the guidelines generally determines who benefits from the guidelines. And there's actually different schools of thought about how data should be shared, and it's not all under that one framework. So, I mean, the biggest barrier to data sharing is the time required. I included a link to the Tri-Council Data Management Consultation Summary that was recently released, and the majority of respondents say they just don't have time to actually share their data. We're talking about health data here. Of course, there are ethical and privacy considerations to sharing data, and these are things that you need to think about from the outset of a research project. Another big barrier that researchers face, of course, is being scooped. They're scared that if they share their data, someone else will use it to publish results and receive professional benefits before they'll have a chance to themselves. And there's equity concerns. I brought up the example of Indigenous data governance in Alberta. When it comes to research, Indigenous communities have been historically exploited by researchers taking data for them and never sharing benefits back. These concerns exist when there's data sharing and secondary data use, that people could use the data and even make harmful conclusions about Indigenous communities and never involve them in the secondary data research as well. So those are some considerations that people think about when they're considering how they might go about sharing data. Just to talk a little bit about the public good, meaning being a public good means it's good for the public, and public goods are, of course, resources that anyone can access and use without taking away from anyone else's use. I think there's been a bit of an overemphasis on open data as being the method of data sharing, and there's some evidence that this actually hinders building collective resources with shared data. I linked to a paper that I wrote that I did my PhD thesis on. This was a large international collaboration of researchers trying to share bioconservation data. And what we found was, even though this is a Genome Canada funded project where the rule is that you have to share your data, these mosquito species data that's in the database, these are all very important public health species that it'd be great if all this data was shared. And those numbers are showing what percentage of the data that was created that's used on the dashboard that was actually made public. So even though they were required to do this, people aren't sharing the data necessarily. And this is just showing how there's a difference in the behavior of different groups that might be sharing data. So this is just showing the number of published mosquito records of total of those 3 species in countries of varying income levels. So you can see the vast majority of mosquito species being shared in that project are coming from high-income countries, which is interesting because, as some of you may know, the vast majority of disease burden from mosquito-borne, mosquito-transmitted diseases like malaria and yellow fever are in low-income countries. So even though these countries would likely benefit the most from having more research done on these mosquitoes, they're not sharing data related to those mosquitoes for various reasons. Another thing to think about is who's creating guidelines as well. So I talked about the FAIR guidelines for data sharing. These are really common. You're going to see them all over the place, but they don't take into consideration other worldviews about data, and they certainly don't take into consideration Indigenous worldviews about data. So in response to the FAIR principles, the Global Indigenous Data Alliance, and there's a link there as well, produced the CARE principles. So they say be fair and care, and keep these principles in mind as well. So you can see that there's a very different approach to how data should be shared from their perspectives. And as I mentioned, who's creating these guidelines really determines what the guidelines are. So this is just showing the FAIR data principle authors, and the Toronto guidelines is the Toronto International Data Release Guidelines for Genomic Data Projects. And you can see that the majority of the authors on projects like these are coming from Western countries, very wealthy countries as well. If you look at where the authors of the CARE data principles are coming from, there are a lot of Indigenous authors or people who are working with Indigenous communities for sure, and they're also coming from a much wider range of country income levels as well. So now that we've talked about some of the things to think about when you're planning your data management and data sharing, we'll talk about how to actually go about doing data management as well. And I think that the big thing to think about is your end goal isn't sharing data. Your end goal is managing your data to ensure that you are reaching the goals of the research that you set out to do, or ensuring that you're not producing harms by sharing your data for unintended uses and things like that. So you really need to start with data management before you even have your data. This is something you need to think about when you're planning informed consent, because if you're collecting data from humans, you need their permission to share the collected data. So for those of you who have not gone through any kind of ethics review processes, you need to be really clear and explicit about what you're doing with data that you collect from people. And this is the same actually with data that governments collect from their citizens as well. Whenever you're collecting personal information, you need to let people know what you're doing with it as well. And I included a couple links to articles that talk about the ethical issues in more depth as well. Something that is really important to think about if you're a research-based student or a researcher yourself is that a lot of the funding agencies are starting to require data management plans when you're applying for funding in the first place. So, and I just always want to emphasize this, data doesn't have to be managed to be open and unrestricted. You want to think about what the goals of the data set you have are and what data sharing strategy will help you achieve those goals. So data sharing is not an end in itself, although I think that it's a good thing to do, but you need to think about why you're doing it and what goals that's supporting and how to support those goals most effectively. For an example, a recent data management plan that I put together with my research team was looking at bacterial genomics, but these bacteria were collected from Indigenous people living in Northern Canada. So even though the standards of the genomics community for decades since the Human Genome Project in the early 2000s have been that genomic data should be released openly and freely as fast as possible, our data management plan actually puts the control of how the data is released, even though it's microbial data, under the control of committees in the communities where people have donated the biopsies that the bacteria was cultured from. I can't give you better information on how to do data management than what's already out there. So I'm not going to go through the nitty-gritty of what a data management plan should entail, but Portage Network is a phenomenal resource to go through and actually build a data management plan. They have a great tool that allows you to, it asks you questions to answer about how you're collecting your data, what kind of metadata you need to collect to make it usable by someone else in the future. So metadata is data about data, so it might be things like when you collected a piece of information or stuff like that. It forces you to think about storage and how you're preserving your data. Do you want to keep it on your own server? Maybe you have a website, do you want to store it there? Well, that doesn't have the same kind of long-term viability that an institutional repository would have. And it helps you think about how people might access your data and reuse it later, and the issues around what responsibilities you have regarding this data, who are you accountable to, what you should think about, and ethical and legal concerns as well. Include some links to the Research Data Alliance as well, which is a great international group of people that are working to develop guidelines for international research data. And Research Data Canada also is a fantastic resource to learn more about actually producing good scientific data management. And that was all I wanted to chat with you about from the outset. So I will now stop sharing my screen, and thank you so much for listening.
Thank you so much. That was excellent. And while Naomi gets her slides on the screen, we can take any questions of clarification that are directly pertain to what you just heard from Janis. Otherwise, we'll save most of our discussion until the end. I'm not seeing any come in. So Naomi, you're welcome to get your slides, to share your slides. Great, I see them. And then,
all right, they're all working here?
Yep, I can, yep, looks good.
Okay, perfect. All right, so thank you so much for that, Janis. I'm gonna kind of go talk a little bit more about secondary data analysis with complex data. So Emma already introduced me. Oh, I can get this, there we go. Emma already introduced me, but I just wanted to highlight that my own research looks at quantitative epidemiology. So essentially, when you're doing epidemiology research, what are the methods that you're using and how appropriate they are they for the purpose of your research? So data management and data use. So data management and data use are very intrinsically connected. How you manage the data, how it's collected, how it's stored, all of that is going to impact how able you are to use the data for your research purposes and what sort of confidence you're going to have in those results. So what do you do when you're not the one collecting the data? And this happens when you're doing secondary data analysis. And so this can either be if you're using, say, data from an open resource, like the ones that Janis highlighted. It could be data within your own research group. It's not uncommon for research labs to collect sort of a database that they'll then sort of ask different research questions to. Or it can be with data from external sources, such as the Canadian Community Health Survey, census data, or administrative health data. And it really kind of, for me, what I want to talk about is how does the data management impact the interpretation of your results? How can you make sure that the results that you're coming up with are actually appropriate for the data that you've got and for the methods that were used to collect that data? So there we go, using secondary data for population health research, ensuring appropriate use and interpretation of the results. So when we're talking about appropriate use of data, it's really impossible to not talk about data quality. So data quality is essentially fitness for use. So how well can I use the data that I have here for the purpose that I'm wanting to use it for? And it really does depend on what you're using it for. So you can have a data set that has really great data quality for one research question, and when you try to apply it to another research purpose or research question, it might have poor data quality. So it really does depend on what you are using the data for. And you can assess data quality with what's called a data quality framework. So there are a number of data quality frameworks out there. Some examples are the Manitoba Centre for Health Policy, they've got one. Canadian Institute for Health Information, or CIHI, has one. Statistics Canada, Public Health Agency of Canada. In my last slide that I've provided, it does have links to all these different ones, so if you're wanting to look into them. They do all sort of have consistent sort of underlying themes, although there are differences because the type of data that these agencies work with are a little bit different. I'm going to focus on the one at the Manitoba Centre for Health Policy for two reasons. One, that's the one that I primarily use, and it's also made for administrative health data, which is what I'm going to talk about a little bit later as an example of thinking about how the quality of your data impacts the types of conclusions you can draw. So they've sort of broken data quality down into 6 different components. So accuracy, so how well does the data represent what's needed? And there's sort of 2 subcomponents, one being completeness. If you have a lot of missing data, obviously it's very difficult to come up with an accurate assessment of what that variable is, especially if your data is not missing at random. A really great example of this is survey data. There tends to be a reporter bias. So people who, I guess, are higher SES have more time to answer these surveys. For example, in the Canadian Community Health Survey, they're more likely to respond. And so when you have missing data there, the actual results that you're getting might be more generalizable to the people that responded and less generalizable to the people who didn't. And then correctness. So it's not uncommon for people, when you approach, say, an open data set or secondary data analysis, to just sit down and start doing analysis, not actually think about what that data are. So a great example is if you have BMI. I can have a variable that says BMI, and I can't assume that it's simply completely accurate if I don't look at how it was actually measured. It could be self-reported, and we know that when people self-report data, there tends to be some biases. So for BMI, women tend to underreport their weight and men tend to overreport their height. So it kind of goes back down to looking, what were your methods and how do those methods impact how correct my data actually are in representing what I'm wanting to measure. Internal validity. So things like internal consistency. Essentially, if you look at your data set and you see that there's a male who has flagged as being positive for pregnancy, that's not very consistent. Clearly there's an error here. Another way that you can look at internal consistency is things like ranges that you would expect, going back to the BMI range. If you have a BMI of 2, not really possible, so there's something wrong going on there. You can also look at things like stability across time. A really great example of this was one of my fellow VEDA trainees was talking about some work that he did in the internship, and it was looking at, I believe it was, I'm not a basic scientist, so excuse me if the terminology is incorrect, but I believe he was looking at DNA sequencing and sort of the results that they were getting over time and the variability. And he found that there was one year where the variability just shot completely up. Error rates were really ridiculous. And the reason for that was because they had just gotten a new machine. And so things, when you see that your trends over time tend to have like weird outliers and whatnot, that's usually an indication that something's going on that's not necessarily representing what you're wanting to represent, but there's an issue with data quality where you're not getting the most accurate results. External validity, so how well does your data correspond with external data sources? And this can be done either at the individual level. So for example, in administrative health data, when we're wanting to look at its validity, oftentimes we'll link it to, say, clinical registry data and see how well do those two sources agree. Or you can look at it at a more ecological level where you've done your analysis, you have these results, how well do those results agree with other published studies that have been looking at the same research question. Timeliness, how current is your research? So oftentimes with secondary, or how current is your data, sorry. Oftentimes with secondary data analysis, you'll be working with data that might have been collected 10, 20 years ago. And especially when you're thinking of public health, our understanding of diseases have evolved over time. A great example of this is heart health in women. Over time, we've realized that the symptoms that women have for cardiovascular disease are not the same as the symptoms for men. So you can't sort of put them both in the same box. We need to consider sex when we're looking at cardiovascular disease. So if you got a data set from, maybe 10, 20 years ago, it might not be taking that into account, and you might be missing some symptoms for cardiovascular disease for women that you wouldn't be if you were looking at a data set that was collected in the past 5 years. Interpretability, obviously, how well can you interpret your data for the question at hand, and then value, how valuable is your data, again, for the question at hand. So I'm going to talk a little bit about administrative health data and use that kind of as an example of data quality and how your data quality impacts sort of what you're able to tell policy and decision makers in terms of what their bottom line is. So administrative health data, if you're not familiar with it, it's data that's collected for administrative purposes, such as financial reimbursement. Here in Canada, we have universal healthcare coverage, so and that's managed by the provinces primarily. So every time you visit your doctor, they'll submit a billing code that has a disease code attached to it to the provincial government to be reimbursed. And that's sort of the collection of administrative health data. So it consists of things like physician billing claims, hospital discharge abstracts, and prescription medications within some jurisdictions, not all. It's also really unique in that it's able to track people over time, assuming that they stay within a single province. So if you're born and raised in a province, that administrative data is collecting over time for you, and then we can take a look at that and sort of see how health is changing for that individual. Obviously, it's all de-identified, but it has a capability to do that. And it's an excellent data resource for population health. As I mentioned, because in Canada we have universal healthcare, it gives us population health coverage, which isn't always accessible in all countries. So it's really fantastic for that. So advantages, population health coverage. I mentioned you can look at health over time and how it's changing. It also allows us to look at rare diseases. So because you've got that population coverage, we have a really large database that can allow us to find rare diseases and follow these people over time in a more prospective cohort methodology. Oftentimes with rare diseases, it's sort of more limited to case control studies if you're doing primary data collection, but with administrative data, you're able to do that prospective cohort study. Minimal cost, the data is already being collected. And it's also really great for looking at what's called disease incidence or new disease cases. That's really exciting for me because my own thesis research is looking at chronic disease surveillance. So we're interested in things like new disease cases, existing disease cases, or disease prevalence. The disadvantage is that it's not actually collected for research purposes. And that kind of brings us back to the data quality. If it wasn't actually collected to be used for research, how well can we apply it to our research purposes, or how fit is it for research purposes? So I'm going to talk a little bit about how we need to think about the data to ensure the appropriate application and interpretation of the results, using administrative data kind of as an example. So the questions that you need to ask yourself, and ideally, you'll be able to answer these questions with good data management. I mean, it gets a little bit sticky when data management's poor and sometimes you have to make some assumptions, but these are the types of things you want to be thinking about when you're doing that secondary data analysis, and not just sitting down and doing the analysis and not thinking about what's actually in your data. So how are the data collected? In the case of administrative data, it's usually submitted to the province or territory for reimbursement purposes. Who collects the data? It's healthcare professionals. So with research studies, you're able to do things beforehand in pilot studies like inter-rater reliability, stuff like that. That's not done with administrative health data. So you have to keep in mind that there are going to be differences in terms of how one physician codes diseases and how another physician codes diseases. There is some standardization with what's called the International Classification of Diseases, but there still might be a bit of a clustering effect in that not all physicians code diseases the same way. What factors might influence the quality of my data for intended purposes? So I kind of have touched a little bit on this, like healthcare professionals might have slightly different coding practices. International classification of diseases. So this is the coding that's used to represent diseases in the health data. And there are different versions over time. So right now we're on ICD version 10 here in Canada, but there's also ICD version 9 and ICD version 8 tends to be the ones that provinces have access to. So how do you think about disease when, 10, 20 years ago, the way it's coded in the data is going to be different from how it's coded now. And it can make it difficult to compare health over time. And then I already mentioned this, the changes in disease understanding and treatment. You can have new clinical practice guidelines that come into play that's going to change how the diseases are represented in the data. Some doctors have incentive payments, so they may be coding for a disease a little bit more frequently. And salary versus fee-for-service physicians. So some physicians aren't actually paid per patient that they see. They're actually paid on a salary basis. And then they're supposed to submit what's called shadow billing. So submitting those billings to the province, even though they're not actually being paid. And my research group has done a little bit of research on that, and they found that physicians that are paid via salary tend to have lower data quality than physicians that are paid for fee for service. So that can also affect your data quality. Is there a way for me to measure or assess my data quality? So in the case of administrative health data, there's usually some preliminary checks that are already done by data holders. If you're getting it from an open data set, they've probably already done a little bit of data cleaning. But there's always going to be some work that you're going to have to do yourself. So for example, there can be validation studies that you might be the one doing the validation study. So linking, say, like administrative health data with the clinical health registries to see how accurate are the data. You can also do internal checks, like birth dates. Is there someone in my data set that's 400 years old? Yes, well, that's probably wrong. Things like coding consistency, looking to see how did they code missing data, and does that, do I need to sort of recode that? Because if they code missing data, say like 999, and then I do, calculate my mean and median and whatnot, that 999 value is going to throw things off if my statistics program doesn't know that that's a missing value. How might these potential threats to my data quality impact how I interpret my results? So in the case of administrative health data, it might be that you're not actually measuring changes in population health, but you're actually measuring changes in coding practices. Going back to that BMI example that I used, if you have self-reported BMI, that might change how you relate BMI to your factor of interest. You might be able to apply a correction factor to sort of correct those self-report biases, but you want to be aware of how those potential threats to your data quality will impact what bottom line you're saying with your results. And then what populations can I generalize to, and can you ethically do that? So Janis talked a little bit about the Aboriginal data within Alberta, and same thing in Manitoba here. The data that you get might not contain information from certain populations. For example, administrative data doesn't contain populations that are covered by federal jurisdictions, which include Aboriginal peoples. And then if it does contain it, you generally have to go through an extra ethics step to actually use that data or get access to that data. And so you need to be aware of who's actually in your data. Can you generalize it to generalize your results to that population? And then good data practice, document. Like I said, just because you're doing secondary data analysis doesn't mean that there aren't things to document. So any data quality checks that you do, any changes that you make to the data set, you need to be sure that you record what you did and why. Especially when you're working with an open data set, because you'll have people that are doing similar analyses, and you might find that you get different results. And then the question is always, well, why did you get the different results? And it might be that maybe you chose a different cutoff point than the other person. And so you need to be able to look at that and see where your differences are and what you did with the data set. And then also, say if you had a reviewer asking questions, be able to justify why you did what you did. So I'm just checking what time I'm at. Okay, I'm gonna speed through this really quickly. This is just an example of how administrative data can be used to inform health policy or be used by policymakers, and sort of how data quality affects what we can say about it. So I'm going to talk a little bit about a study that I did with the Canadian Chronic Disease Surveillance System. It's an initiative of the Public Health Agency of Canada, and they collect national estimates of chronic diseases using what's called the distributed surveillance system. The methods that they use go through a really rigorous data validation process. However, because we're still working with administrative data, we are still subject to data quality and how that changes over time. So the paper we published looked at trends in chronic disease incidence. from the Canadian Chronic Disease Surveillance System. And what we wanted to do was assess the direction of chronic disease incidence trends as well as their linearity over time. It kind of goes back to that internal validation of your data. If we have unexpected directions of the trends or sudden changes, it can indicate that there's a change in data quality and not necessarily a change in public health. So we used a negative binomial regression model to look at the trends, and then with the time we added, we then looked at a spline model to assess how linear the disease incidence was over time. And then we used a logistic regression, a likelihood ratio test, or an LRT, to determine whether or not the spline, the model with this time as a spline or nonlinear, was more parsimonious than the model with time as a linear effect. So these are some of the results. This is the predicted values. It's not the actual data, but you can see that there's sort of two lines. There's a linear one and the restricted cubic spline. And for all these three diseases, the likelihood ratio test found that the restricted cubic spline was more parsimonious than the linear model. And same thing here before. So ischemic heart disease and stroke, we found there was actually no difference between the linear and restricted cubic spline. So therefore, these trends are truly linear. So the main results was we found that there's a gradual decrease in disease incidence for all the diseases except for diabetes. But there was a presence of nonlinear trends. So that kind of provided us a springboard for looking at data quality. It's like, what's the driving force behind nonlinearity? Is it actually that there are changes in public health that are nonlinear, which it very well could be, or is it that there's changes in data quality? So we looked at diseases at a national trend, which is those at a national level, which is the figures that I showed you there. But we also did look at the trends within jurisdictions, and there were differences between them. And so the question then becomes, are those differences due to different health in the population within the provinces, which is very feasible. I mean, someone with someone's health profile in BC is going to be very different from someone in Manitoba versus the Atlantic provinces. Or it could be the way that the physicians code the diseases in that jurisdiction is a little bit different. So these questions are sort of things that are asked by the CCDSS Data Quality Working Group. So this group was formed in 2016, and their purpose is to conduct ad hoc data quality studies. So this kind of provided a really great springboard for them to start asking things about why we're seeing what we're seeing. So it's an example, and that is the end of my talk. Are there any questions?
Thank you so much for your presentation, Naomi. And yes, we'll now take questions. So please type any questions that you have in the Q&A. Your questions can be for either Naomi or Janis. There is, we do have a couple of questions already. So one, you talked about outliers that you might detect when looking at your data. So what do you do if you do detect a significant outlier in the data set? Would you automatically exclude the outlier in the analysis or take some other action?
Oh, that's such a good question. I would not automatically exclude it. I would ask, why is there an outlier? So for example, you might find that this individual is an outlier because they're very different age than the rest. Like, yeah, my first question would be, why are they an outlier? Is there any sort of reasonable explanation for that? And if you do exclude it, you do need to have a good reason for why you excluded that outlier. A great thing to do when you find an outlier is to be aware of it and do a sensitivity analysis. So do your analysis with the outlier in there, do it without, and see if there's actually any change in the results. When you start excluding outliers, what happens is you sort of reduce what's called the variability of your data set. So you're basically restricting your results to everyone who has, that data or those sort of similar characteristics, and you run the risk of essentially coming up with a result that's only applicable to a very slim population. So the more data and the more variability you can include, the better. Obviously outliers are a bit of a headache, but the first question is, why is there an outlier? Is it actually a feasible outlier? Is it something, like I said, a BMI of 4? Can you explain it? And then if it's a feasible result and it isn't something with data quality, when you include it, does it actually change your results? And how does that kind of affect the generalizability of your results? That's an excellent question.
Thank you. I don't know, Janis, if you want to add anything to that question or add a response.
Nope, that was great. My gut was also, no, definitely do not automatically exclude anything ever. So
Okay. So we do have another question. Naomi, are you able to expand on ghost billing? What would be a typical consequence for capturing chronic diseases following validated case definitions?
Right. So, yeah, so shadow billing is what it's called. And as I mentioned, physicians are normally paid through a fee-for-service plan. So every time that a patient comes to visit them, they'll then submit a billing code to the province to get paid. And so there's obviously a very high incentive to submit that, because if you don't get paid. And they found that they implemented, they started to not do that for particularly rural physicians, because I guess if you're in a rural setting, you tend to see less patients, you get paid less than your urban counterparts, and then it's a lot harder to recruit doctors to a rural setting. So they started to do the salary approach. So you get paid the same amount no matter what, but you submit those billing claims as you would normally, as if you were getting paid. But because that financial incentive is removed, physicians are less likely to actually submit them. So the study that I'm thinking of, and I can't remember the exact reference, but they looked at diabetes, and they compared sort of when you apply the case definition for diabetes in physicians that are on fee-for-service and compared it to physicians that are on salary, what does that look like? And they found that the physicians that were on salary, there was actually a much lower case ascertainment for diabetes, to the point where it was, I forget what exact methods they used, but essentially the results were that we're seeing less diabetic cases, but it's not actually because there's less diabetic cases, it's because there's less data of the physicians submitting those billing codes. The results is that you'll tend to get false lower disease counts.
Okay, thank you. And then obviously that could have consequences for how policies are made, or do you know of any, can you speak to the longer term consequences?
Longer term consequences, if you're not taking that into account when you're looking at your sort of disease counts, is that those areas that are having lower disease counts are going to have less resources, because oftentimes policy and decision makers are going to look at those counts to do their sort of planning for the healthcare system. And so they're going to think, well, these people are healthier, therefore we need to send less doctors, therefore we don't need to fund their hospitals quite as much, which obviously is not very good for public health.
Right. Okay, thank you so much. Now we have another question, and maybe Janis, you want to take a first crack at this response. You mentioned Indigenous data a few times, and I'm wondering how OCAP influences the data management principles that you discussed at the start of the webinar.
Great question. I'm really happy to have more time to discuss some of those issues. So OCAP is a First Nations concept in Canada, for those who are unfamiliar, that talks about the ownership, control, access, and possession of First Nations data. Someone else speaks from within, from an Indigenous scholar perspective, would like to write out some more, and maybe I can actually include a link to OCAP to send out to everyone as well, Emma. That might be helpful. I see it's been marked as answered. I'm just gonna, okay. How has it influenced data management principles? So it hasn't consistently influenced principles in the way that I think it should across the country. It's going to be really kind of a patchy implementation as far as governments are concerned. I know with health data in Alberta specifically, when it comes to anything about accessing data, OCAP is the guiding principle that groups like the Alberta First Nations Information Governance Center are using to explain and determine what their data access and expectations are around that. I do not see OCAP mentioned outside of Indigenous health research, specifically when looking at the Canadian research landscape. So if you're specifically working with Indigenous communities and submitting things to CHR through the Indigenous Health Research Peer Review Panel, OCAP is very prominent, and it is something that you must mention and must be aware of, and must mention those principles when you talk about your data management. But if you're submitting data, or if you're submitting a grant to CHR, and you're reading data management strategies in general, you are not going to just passively come across OCAP. It's not integrated much the same way it should. So what I think is there's a real problem in that researchers who aren't specifically working with Indigenous communities and know, oh, I see someone just posted the link, thanks so much. If you're not specifically working with Indigenous communities and seeking out information about what OCAP is and how to be responsive to First Nations principles about data sharing, you are not going to come across it. And this comes into play when I was talking a bit about how the different worldviews about what data aren't always represented. And that's why it's really good to look at who's writing these guidelines and what worldview they might be coming from. I think in some disciplines outside of social sciences and people working with marginalized or diverse populations, tend to forget that they have a worldview, they don't have the worldview. So it's really important to go into anything around data management to remember that your approach and the dominant discourse about how these things should happen in your discipline might not be the only way to think about that. And seeking out other views about the principles underlying why these things are done are always a great idea. So to answer your question more succinctly, I guess, is it's not that influential outside of Indigenous health research that I found.
Great, thank you very much. Naomi, is there anything else that you would like to add?
No, that was excellent, very eloquently put.
Okay, great. So our next question concerns emerging trends that you may have seen in data quality or indicators in administrative data that are helping us to better understand equity issues. So, for example, improved disaggregation related to gender or income or geography.
I can't exactly speak to what kinds of emerging trends we've seen. I can talk about how they can be used. Yeah, so when you're looking at data quality that's a really great question. When you're thinking of data indicators in administrative data, they allow us to look at health in different populations, so you can sort of aggregate or disaggregate them by I would note with administrative health data, we can only look at sex. We can't look at gender-based analysis because we don't have that data. But you can look at separating it by sex and seeing what the different trends are. You can look at different populations, like their SES, how those trends differ. And I know that there has been a number of analyses, and so these ones were actually coming out of Alberta, that looked at sort of health trends in Aboriginal populations because they have that data and they could access it given they went through the correct ethical channels or ethics channels, and they could look at how those trends differ between Aboriginal individuals and then the general population. So yeah, I guess to answer your questions, I would say that it allows us to look at these issues in a way that we might not necessarily be able to do with other data sources. Yeah.
Okay.
That's a tough one.
Thanks, Naomi. Anything else that you would like to add to that, Janis? Or
Nope, I am not familiar with trends in administrative data in general. So.
Okay, terrific. So let's, I see another question has, so to elaborate on that specific question, the person asking the question was hoping that gender was maybe starting to be collected in addition to sex. So what do you think we need, what's it going to take?
Yeah, that's a really great question. It's funny because I just was at a network meeting and we were one of the presenters talked about sex and gender-based analysis. And this is something that I know the Canadian government has started to really push with Canadian health researchers, is talking about the different effects of sex and gender, including that in their analysis. With administrative data, some of the provinces have started to incorporate a more gendered approach. There is a little bit of a bias, I would say, with health researchers, where they'll tend to think, well, we're only working with sex, it's not that big of a deal, and not recognizing that gender does play a role in how individuals interact with the healthcare system, and it's going to play a role in sort of what sort of conclusions you can draw. So I guess with the sex and gender thing being included in the admin data, I would say that it's coming in some provinces. It's going to be a while, though, I think, before we can actually use that data. And that kind of goes back to down to the data quality. We can't look at it at a national level if only a few, some provinces have it and some provinces don't. And then most people might not be aware of the fact that they can have that data in there. So it's going to sort of, if you think of like a prospective cohort study, we can't apply that sex and gender indicator retroactively if the individual isn't active in changing that and saying, well, at this point, this is where I identified. And so it's kind of like a prospective thing where it's going to be a little bit a while after we've incorporated that sort of sex and gender differentiation in the data before we can actually use that in our analyses.
I was just curious, so I just quickly Googled the Canadian census, and they are finally in the 2021 census going to have a more, a better look at sex and gender versus just sex. So if you just Google it, there's a whole write-up about how they did consultations and things like that.
Yeah.
So at least in the census, it seems to be moving towards that.
Yeah, and hopefully, like, I mean, you can link some census data to admin data. So you're able to do it kind of by linking through other sources. I'm wondering if Canadian Community Health Survey might have something about that too. I'll have to look into it, but yeah. So there are some linking sources you can do to do it, but there's definitely on the forefront in terms of an issue with public health research.
Great, thank you for that question, and it sparked some good discussion. So I know, Naomi, you mentioned a few data quality frameworks, and we have the links for those that will be shared in the slides. And you say they sort of differ in terms of the type of data that they are assessing. But can you say a little bit more about the differences or similarities in those frameworks, and if some are might be better in some?
Oh yeah, that's a great question.
Or if you see that maybe there are still gaps in terms of how quality is assessed.
Yeah, like it kind of goes back, and the example that I gave before with data quality, you can have good data quality for one thing, like it's the exact same data set, good data quality, and then have poor data quality for another. So, I mean, in terms of which one's best to use, it's going to depend on the type of data that you're using. So for administrative health data, CIHI has good data quality framework for their hospital discharge abstracts, because that's what CIHI does. And then MCHP, or Manitoba Centre for Health Policy, is very much so for the broader administrative data. And I have to look a little bit better into the one by PHAC and Statistics Canada. They tend to have common underlying, like the accuracy and internal external validity. Those ones are pretty strong throughout. But when it comes to different things in the data, so for example, timeliness, especially with administrative health data, when they've got changing ICD code versions, that's a really big one. But it also might depend on what data you're working with. So I guess my answer to that is it really just depends on your data and how closely it aligns to the data that data quality framework was developed for. I know there's a fellow that he's doing his master's degree in my research program who's looking at data quality for unstructured text data, which is a really interesting piece of work. But yeah, so